sir.
Okay, so Mehmet is the most senior. Mehmet, let's start.
I will just let you ask the speakers south. It will be a
Okay,
nice
sir.
meeting, I'm sure.
Okay, sir. I'm ready. Sandeep, you want to say something before we start?
No, I think the first talk is on the NRP session, so let's start with that.
Okay. Dear participants, Mr. President, we have Dr. Salman Sharif, the President of the World Spinal Column Society with us. So he's not only a speaker, he is the president of this society. We're happy that he's here and he's giving his time for the participants of this course. The title of the course today is, this is a series actually of how I do it. You listen to experts in spine surgery and you gather practical information regarding how they do a specific technique. So today we are going to talk about subaxial spine. We are having some reminder of the anatomy around this area first, and then we will have two important practical notes from Dr. Sandeep, Vaishya, and Dr. Salman Sharif. So let's start with talking about subaxial cervical. I'm having co-directors or moderators for this session. Professor Mehmet Zileli, the famous spine surgeon and professor from Izmir, Turkey, and the ex-president of the World Spinal Column Society. Thank you, sir, for being with us. And we have Sandeep Vaishya, the treasurer, the current treasurer of the World Spinal Column Society and the rising star in the field of spine surgery in Asia and specifically in India. He's a pioneer of a lot of things, and he's currently the consultant of neurosurgery in Fortis Institute, the strong institute of surgery and spine surgery in India. Thank you, Dr. Sandeep, for being with us, and he's going to be a speaker as well. Let's start by Dr. Yousuf Shaikh, Senior Registrar of Neurosurgery in the Department of Neurosurgery in Liaquat National Hospital in Karachi. He is the employee of Mr. President Salman Sharif. So I think he trusts him so much, and when Salman Sharif trusts someone, we all trust him. Dr. Yousuf, ground is yours.
Okay, thank you. So I'll be sharing my screen now. So is it visible to everybody? The screen is visible?
Not yet, it's coming.
I click on new share.
Now share it again.
Okay, so it's working now. Go ahead, Dr. Yousuf.
I'm going to put it on full screen. Okay.
We can't see your slides.
Is it okay now?
No, Yousuf.
No, I think it's starting, but it's slow in showing there. It's not shown yet.
Whenever I
Mehmet,
put it on
you,
full screen, it disappears.
Mehmet, can you help? Can you help with that?
So I think it's your internet issue, I think.
Oh,
Yeah.
now we can
It's
see.
visible. Yeah.
Now it's showing, but just put them on.
It's full screen now.
Put them as a slideshow, please.
I've put it on slideshow. Can everybody
fine
see
now.
now?
Yes, please.
Okay. So we'll be talking
Okay.
about the.
Oh, now it's working. Go ahead.
So we'll be talking about the cervical spine anatomy today, and predominantly the subaxial cervical spine. Now I will try to keep this talk very short, limited to 15 minutes, because most of the clinical aspects will be covered in the upcoming lectures of ACDF and lateral mass. So we will be predominantly focusing on the anatomical aspects. So considering the cervical spine, we know that we divide it into two major aspects, the upper and lower. The lower cervical spine is what we call as the subaxial cervical spine that extends from C3 to C7. And the predominant movements are flexion, extension, and lateral bending over here. So if we looked at the diagram of the cervical spine, we can appreciate that unlike C1 and C2, the rest of the subaxial cervical spine has more or less similar morphological features. They have a body, they have a lateral mass, upper and lower articulating facets, a neural foramen, as well as the space for intervertebral disc. This represents the intervertebral foramen for the passage of nerve. If we look at the cervical vertebrae, we can appreciate that it is having a round cylindrical body. So it is predominantly a cylindrical body with the AP diameter being much shorter than the transverse diameter. And whenever we are approaching the cervical spine from the anterior aspect, we can appreciate that we have quite a big surface area for the placement of plate. So whenever a plate is being placed on the anterior aspect of vertebral body, it will just cover approximately half of it. So you have quite a big area. And you need to make sure that your screws are either directed medially or, if not medially, straight. It should not go lateral. Even if your screw is going a bit lateral, then it is unlikely it will enter the neural foramen unless the plate is very skewed to the lateral. But if you put a plate in the midline, then it is unlikely to enter the neural foramen. So this is the body. Then we have the large vertebral canal for the passage of spinal cord. Now the spinal canal diameter in the cervical spine is the widest of the entire spine. Then we have the facets for upper and lower articulating joints, a transverse process that contains a notch transverse foramen for the passage of vertebral artery. Now this is the C7th vertebra. Occasionally people will address the C7 vertebra anteriorly as well. However, it does have a transverse foramen, but only in 2% of cases the vertebral artery will pass through the C7 transverse foramen. In 96-97% of cases, the C7 transverse foramen is usually empty. If we look at the diagrammatic presentation from the coronal aspect, now I put this diagram to emphasize the importance of uncovertebral joints, because unlike the other joints which are synovial, which are above the lateral masses, which form the articular facets, these are true synovial joints. The uncovertebral joint is not a true synovial joint, and therefore it has no synovium. It is a false type of joint. And as you can appreciate, on the lateral most aspect of the vertebral bodies, these are small elevations, which are known as the uncinate process, and they contribute to formation of uncovertebral joint. Now, the clinical importance of uncovertebral joint is that it actually contributes to formation of the medial wall of the neural foramen. So in most circumstances, whenever you are addressing or operating on a patient who has brachialgia or radiculopathy, it is important that you properly decompress the nerve and take the uncovertebral joint. Leaving the uncovertebral joint intact is likely to cause residual compression on the nerve. Now, if we talk about the pedicles, pedicles are usually the favorite part of the surgeon in the lumbar spine because they provide good stability and use it for the purpose of pedicle screws. But this does not apply in the subaxial cervical spine. Now, if we look at the parameters, we can appreciate that the inner diameter of the pedicle varies from 2.7 to 3.1 millimeter on average. So if it is only 2.7 millimeter, then you need to put a screw that is even smaller than this. A screw smaller than 2 millimeter in diameter will have very less strength and purchase. The second important element is that, as you can appreciate that in this diagram, if you want, this is the pedicle. So if you want to put in a pedicle screw, the direction has to be quite neat. So through a posterior aspect, especially in fat patients, having such a 45-degree angle is quite difficult, and you need to do a lot of muscle retraction. Other than that, it usually does not make sense to utilize this small portion of the pedicle and probably jeopardize the possibility of injuring the vertebral artery here and the spinal cord over here. So I'm not saying that the pedicle screws cannot be placed. Yes, the pedicle screws can be placed if you are a very experienced surgeon or you have neuronavigation, but they do not offer any significant advantage, and such a risk is not worth it. Better purchase and better stability can be achieved with lateral mass screws. So we have an alternative. If you look at the lateral aspect, we can appreciate that if you go from upper to lower cervical spine, the facets tend to get more angulated and from horizontal to more oblique orientation. Now, this oblique orientation is important that it allows the gliding movement of the true synovial joints and flexion extension movements. So you can appreciate that these are the lateral masses which act as posterior lateral pillars having superior and inferior facet joints. Now, this was the diagrammatic presentation that if we were to place in a screw, we enter from the midline or the center point of the lateral mass and we direct it lateral. So on an axial view, it would look like this, and on a sagittal view, it would look like this. Between the vertebral bodies, we have a disco-ligamental structure, that is the disc. Now, I'll not be going into the much detail of it, but we know that the intervertebral disc is primarily composed of water, hydrated proteoglycans and protein. And with the passage of time, as the disc degenerative process comes into play, the protein content begins to decrease. And with disc collapse, it is this jelly-like nucleus pulposus that tends to come out and press onto the nerve. These discs collectively contribute approximately 20% of the total height of the cervical spine. And their vertical distance also tends to increase from upper to lower. At C3, the disc height is 16 millimeter, whereas at the level of C7, it is 20 millimeter. This diameter or preoperatively determining the height of the disc is important, as it will help you identify what sort of cage are you going to put in. Because pre-procedure, you need to be aware that what cages are available. And if you're doing a corpectomy, then a large pyramesh cage is needed. Because we know that in cervical spine, the cages have to be slightly bigger than the designated disc space because we need to restore the normal lordotic curve. But over distraction at the same time should also be avoided. If we talk about the ligaments which contribute to the stability of the cervical spine, these include the anterior and posterior longitudinal ligament. The anterior longitudinal ligament is quite a thin, broad sheet that runs along the anterior border of the cervical spine. And these anterior longitudinal ligament in turn has various deep fibers, intermediate fibers, and superficial fibers depending upon the number of levels it extends vertically. The major objective of ALL is that it tends to restrict the hyperextension and axial traction, and it is adherent to the vertebral bodies as well as the disc space. So in patients, when we are doing an anterior approach, the anterior longitudinal ligament has to be incised in order to gain access to the disc or do a corpectomy. So the ALL has to be removed. Now, if we talk about the posterior longitudinal ligament, in contrast to ALL, it is relatively a thinner band. The diameter is reduced, but it actually is quite thick compared to ALL. It is approximately 3 to 4 times thicker in cervical spine compared to the thoracolumbar spine. And the major objective is basically opposite to that of ALL, that is restricts hyperflexion and axial traction. And because of its central midline orientation, it also resists the midline disc herniation. This is one of the reasons that the disc herniation tend to occur over the lateral aspect, that is over the foramen. And whenever we are approaching a disc from the anterior aspect, when we do an anterior discectomy, occasionally the posterior longitudinal ligament is thickened and has to be removed as well in order to completely fuse the dura. Sometimes this may undergo calcification to form OPLL, that has to be removed again. But in most circumstances, if the posterior longitudinal ligament is thin and it is adherent to the dura, then usually no extra effort should be given to remove it specifically if it is likely to cause dural injury. But if it is thick and if it is causing pressure, then it has to be removed. The other ligaments which contribute to the stability of the subaxial cervical spine, other than ALL and PLL, are the intertransverse ligament, supraspinous ligament, interspinous ligament, and ligamentum flavum. Now, ligamentum flavum is also an important ligament, and it is also referred to as yellow ligament because of its distinctive yellow-like coloration. Now, ligamentum flavum tends to span the interlaminar space, and it extends from the inferior border of upper lamina to the upper border of lower lamina. So whenever we are doing a posterior approach to the cervical spine, other than removing the lamina, the ligamentum flavum is also one of the culprits which in degenerative spine can undergo significant thickening and has to be removed as well. Sometimes it is so thick that it is causing buckling phenomena because of the movement and has to be removed. So if we talk about it in a sagittal MRI, we can appreciate that the blue line indicates an anterior longitudinal ligament, the pink line indicates posterior longitudinal ligament, the yellow lines indicate ligamentum flavum, and then we have this green on the apex of the spinous process indicating supraspinous ligament. Similarly, this is the cadaveric dissection showing the nucleus pulposus that has protruded out, and this is the case of disc prolapse causing compression on the spinal cord. On the sagittal MRI, we can also appreciate, and as I mentioned previously, that whenever we're doing an anterior approach, anterior discectomy, after removing the disc, the PLL, if it is significantly thickened or causing pressure, has to be removed as well in order to completely free the dura. Now, I will not go into the details of the tracts of the spinal cord, knowing the fact that the spinal cord has an H-shaped gray matter and then various ascending and descending tracts. It should be okay for now. We have various ascending, descending tracts. Anteriorly, we have the important corticospinal tracts, and posteriorly, we have the dorsal column. And then we have the posterior dorsal sensory root and ventral motor root that contribute to the formation of the cervical spinal nerve. Now, if we talk about the cervical spinal nerve, we know that, as I just mentioned, it is formed by the union of ventral root and the dorsal root. And the dorsal root carries the sensory, somatosensory fibers, whereas the ventral root carries the motor fibers, which is responsible for the symptomatology. If we talk about it in an axial section, this is again a cadaveric dissection. We can see the spinal cord and a neural foramen. Now, what I'm going to describe is the boundaries of the neural foramen and why did we emphasize previously on the uncovertebral joint. So this, as the arrow indicates, is the uncovertebral joint, the uppermost aspect of the uncus, that is the vertebral body. And as you can appreciate, it is causing significant compression of the cervical spinal nerve. So if you were to do an anterior discectomy and you remove this part of the disc, but leave the exits intact, you leave the exits and the pressure of the uncovertebral joint is there, then the pain will not improve. So you need to remove the uncovertebral joint as well so that the spinal nerve is completely free. So the uncovertebral joint contributes to formation of the medial wall of the spinal nerve or the spinal canal, neural foramen. Then laterally we have the vertebral artery which forms the lateral border of the neural foramen. Then if you look at it from the lateral aspect, we can see that this is the neural foramen. The upper and lower aspects are formed by the pedicles of the upper and lower vertebra, and the posterior lateral wall is formed by the facet joints. Now, as I mentioned that there is ligamentum flavum and then there can be facet hypertrophy. So collectively, facet hypertrophy and ligamentum flavum hypertrophy can also start to impinge onto the nerve. And depending upon whether the compression is anterior or posterior, the surgeon decides which option is better. If we talk about the arterial supply of the spinal cord, we know that the spinal cord has a centripetal, that is periphery and centrifugal blood supply system. The blood supply of the spinal cord is predominantly from the three vessels, the anterior spinal artery and two posterior spinal artery. The posterior spinal arteries are supplying the posterior 1/3 of the spinal cord, and because the spinal cord posteriorly contains predominantly sensory tracts, then even in a setting of bilateral posterior spinal artery injury, the results are usually good. Whereas on the contrary, the anterior spinal artery supplies anterior 2/3 of the cord. And because it supplies all the motor tracts and fibers, injury to the anterior spinal artery is likely to cause complete quadriplegia. And the results are the worst in this case. Now, if we talk about the vertebral artery, we know that the course of the vertebral artery is divided into 4 segments. V1, that is from the origin to the point it enters the transverse foramen. As I mentioned previously, it traverses the transverse foramen of C6. In C7, the only percentage that would pass through its neural foramen is approximately 4 to 5%. V2 as it ascends upward, V3 as it ascends upward through V1 and curves posteriorly, and then V4 represents the intradural portion of the vertebral artery, which then unites with the contralateral vertebral artery to form the intracranial basilar artery. Now, generally, whenever we are addressing cervical spine pathologies, routinely screening or looking at the vertebral artery angiogram is not required. Although there can be variations, up to 4 to 5% of cases can have variations, but until and unless you are doing trauma and the fracture line is going through the transverse foramen, generally an angiogram or a CT angiogram of the vertebral artery is not indicated. The venous system of the spinal cord is again distributed in a similar fashion. There are superficial veins and deep veins. The superficial veins form a very extensive epidural venous plexus, and they allow bidirectional flow of blood. This is also one of the culprits that leads to the spread of metastasis as well as infections in the cervical spine to the adjacent segments. This venous plexus is particularly very, very extensive at the level of C1-2. That's why whenever we are trying to put in C1, C2 screws posteriorly, there is usually an extensive venous ooze, but nothing significant that you cannot control. Usually, the venous bleeding can be controlled easily with the help of pressure and frequent irrigation. Now, I will not be going into the classification that we use for subaxial cervical spine injuries, but it is important that we are aware that there are generally two classifications which are universally used, AO spine and the cervical spine injury classifications. Now, if we talk about the surgical aspects, now most of the surgical aspects will be covered in the coming lecture. But just to give a brief overview, the surgically relevant structures according to the level. Now, usually this is not much emphasized now because prior to the procedure, whenever we are doing either an anterior or posterior approach, the level is usually checked 2 to 3 times by different individuals with the help of an intraoperative fluoroscope. So generally, this is not very important, but it is important that you are aware of it. C2 corresponds to the angle of mandible. C4 corresponds to the hyoid bone. C5 corresponds to thyroid cartilage, and C6 to the cricothyroid or cricoid cartilage. So these are the surface marking of the cervical spine corresponding to the vertebral level. Then there are various types of approaches. We'll be coming on to that. There can be an anterior approach, that is anterior-medial, or anterior-lateral. The classic approach that we use is anterior-medial approach, which is directed between the tracheoesophagus and the carotid sheath, which is predominantly medial to the carotid sheath. And because this is directed anteriorly, we can perform corpectomy, we can perform anterior dissectomy. I have very rarely performed this anterior-lateral approach, but this is generally indicated when there are large tumors, predominantly in the neural foramen, or going across or around the vertebral artery, where an anterior approach would not be ideal to resect the tumor completely around the artery. So an anterior lateral approach is indicated in such circumstances, generally large or laterally oriented neurofibroblasts. Again, a simple diagram showing that if an anterior approach to the cervical spine is used, this is the path to be followed. You give a skin incision, divide the muscles, platysma, medially retract the esophagus and trachea, and then laterally the carotids. And then anteriorly, you are onto the prevertebral fascia that needs to be incised, and then level confirmed. So this is a video where I will be showing the various structures or the skin elements that will be coming from the skin. So first, there is the skin, and underneath the skin lies the platysma muscle. Deep to the platysma lies the sternocleidomastoid, the capitis, and then we have these vertically oriented longus colli muscles. Now, the longus colli muscles have been removed, and they have quite significant clinical importance because generally, whenever we are doing an anterior cervical discectomy, the retractors or the trimline retractors that you use has to go underneath the longus colli muscle. And the presence of longus colli muscles actually help you to keep in midline. Because if you come across a longus-colli muscle, then you need to be aware that yes, you are towards one side. If you are bilaterally at the longus-colli muscle, then you have reached both limits, and then you have to work in the midline. Again, you need to remove some part or go slightly 2 to 3 millimeter maximum under the longus-colli muscle, so the trimline retractors can go in and hold its place. But going extensively under the longus-colli muscle, you will damage the sympathetic chain, and then it will cause Horner syndrome. So there are various veins and nerves in this region, in the neck region. But generally, as I mentioned, because we tend to go in a blunt dissection in a naturally identified plane, usually you will not come across any bleeding. So whenever you are doing an anterior approach, the artery that you protect is predominantly the internal carotid. You go medial to it in an anterior approach, and the various veins that you may encounter. There is no specific area for vein identification, but there can be very diversities as well, significant diversities in venous anatomy. And usually you do not have to take them. The veins are easily retractable. You can retract them, protect them. But in an event of an injury, because of the extensive venous network, the veins can be ligated or coagulated without any significant sequelae. In this region, the nerves that need to be protected of particular importance is the recurrent laryngeal nerve. We know that the recurrent laryngeal nerve tends to hook around the subclavian artery on the right side. And for this particular reason, it is said that the recurrent laryngeal nerve is more at risk of injury on the right side relative to left side. Whereas on the left side, if you go very lateral or very deep, there are chances that you may injure the thoracic duct, predominantly if you are going at a C7, D1 level. But in terms of nerve, the recurrent laryngeal nerve is more at risk of injury on the right side. Other than that, as I talked about, there are cervical sympathetics underneath the longus-colli. So you cannot go more than 3 millimeter lateral or under the longus-colli muscles. Now, there are various clinical aspects or surgical aspects or the steps of surgery that will cover more aspects of the anterior approach and posterior approach. So that will be coming in the upcoming lecture. So this was a very brief overcap and review. And then, as I previously mentioned, these are the sympathetic chain running under the longus-colli muscle. We have the ganglia, and injury to these sympathetic chain or ganglia is likely to cause Horner syndrome. So this was probably the last slide. Thank you.
Thank you, Dr. Yousuf. That was very interesting. Mehmet, would you introduce our next speaker, please?
Yes. The Sandeep will be the next speaker. Am I right?
Yes.
Yeah. Dr. Sandeep Vaishya will present the posture fixation techniques for cervical spine. Sandeep.
So I'll share my screen. Can you see my screen?
Yes, we do.
Yeah.
Okay. So I'll talk about the subaxial cervical spine fixation, both lateral mass and pedicle screw fixation. So the typical indications would be trauma, tumors, degenerative, both OPLL and cervical spondylotic myelopathy. Sometimes as a part of longer occipito-cervical construct or a cervicodorsal construct. Many times in a combined anterior posterior surgery, and sometimes in a rescue procedure if anterior implant fails. Let's start with lateral mass fixation. All spine surgeons should know how to perform this technique because it is very easy to perform and can be easily done freehand. You don't really require any special equipment for this. And it can come as a good rescue surgery in certain cases, particularly if there is an anterior failure. So Roy Camel described lateral mass fixation in 1980s. And after that, Megal, Anderson, and N came with their own parameters for lateral and laterality and the angle of the screws. I generally follow Megal technique, and I'll be just showing that. Now, if you see here, if the screw is directed laterally and directed superiorly, so here is the carotid vertebral artery. This is the entry point. If you direct the screw straight, then it is going to hit the vertebral artery. And if you see in the lateral, here, this is the anterior cortex. And if you take a bicortical purchase, even then you are still safe. But if you take it across too much, then there is a risk of injury to the nerve. So you have to be careful when you take a bicortical purchase. So I will be talking about the entry points and all when I'm showing the video. So now the
Dr.
question
Sandeep,
is whether to, pardon?
can you check your internet source?
Pardon? Hello? Can you see or not?
Yes, yes, we see. Go on.
So the
I'm
question
not
is,
sure if this is happening here or. Okay, go ahead.
What's happening?
No, it's okay. Go ahead.
Okay. So whether to do it freehand or do it under an X-ray control. I normally do it freehand. And but if you are new or you are not confident or if they're not distorted, you can take an X-ray control also. Now, whether to use a power drill or a handheld drill. So I normally start with the power drill, as I will show in the video, and then later I take it step by step forward by a handheld drill. Now, there's a question which side to operate from. Several surgeons prefer to operate, put in the screws from the contralateral side, while some others prefer to do it from the ipsilateral side. I am a right-handed surgeon, so I always stand on the left of the patient, and I tend to put both sides from the same side. So I'll show a short video about the procedure. So I'll just show here the anatomy. So this is the cranial part where my arrow is. This is the caudal. This is midline. You can see the spinous processes here. This is lateral. And this is the right side of the spinal canal, which is exposed. This is the right lateral mass. And as you can see here, this is the lamina, and this dissector is placed at the junction of the lamina and the lateral mass. So this is the medial border of the lateral mass. This is the lateral border of the lateral mass where it dips down. This is the facet joint, superior and inferior facet joint. So you can see this forms the superior and inferior border of the lateral mass. So here there is a square which is formed of the lateral mass. By and large, you draw an imaginary line on this and in the center of the lateral mass. So it makes a sort of cross sign. So this somewhere here, this would be the center of the lateral mass. Many people take this center as the entry point. I tend to go a little bit medial, a little bit inferior to that. And I'll tell you my reason later on. So with the drill, I decorticate and then enter the drill. And up to 8 to 10 millimeters, I do with the power drill. And then, as you can see here, I'm using a handheld drill. I take it right up to 14 millimeters. And after that, I take it forwards in increments of 2 millimeters till I break the opposite cortex. Or usually I don't tend to go beyond 18 millimeters. So even if I have not broken the cortex till 18 millimeters, then I stop it there. I generally tap first few millimeters so that the screw doesn't slip. And you can see here, what is important is when you mark out the entry points, generally they should be in same line, because if you don't mark it out beforehand, sometimes one screw may be lateral or medial, and then it becomes very tricky to put in the rod. And if you apply too much force, then you can break the lateral mass. So occasionally you may encounter bleeding from one of the holes, and the easiest way to counter that is just put in the screw in that hole and it will stop. So I make all the holes on one side and then insert screws sequentially on that side, and then I go to now you can see screws have been placed from C3 to C6 on the right side. And now I'm doing it on the left side. As you can see in the video, I'm doing both the surgeries from the left, both these sides from the left side of the patient. And because there was some bleeding from this hole, so inserted the screw there first. And now once all these screws are inserted, you align them to put in the rod. Now again, there's a question whether to decompress the spine first or put in the screws first. I always put in the screws first because I'm worried that suppose if you have done a laminectomy and then you put in the screws, sometimes if any instrument slips, you can cause an injury to the spinal cord. So I always put in the screws first. So once the screws are put in, you measure the size of the rod, contour it to the lordotic fashion, and then put in the nuts. You should hold the rod firmly because it tends to rotate and then you will lose your lordosis otherwise. So once both the rods are fixed, then you proceed to do the laminectomy. Another reason to put in the screws first is that once the screws are there, when you are decompressing the spine, you know the exact amount of bone to remove. Otherwise, sometimes you can go overboard and damage the lateral mass while doing the laminectomy. So this is the post-op X-ray of the patient. Now, whether to, this we have already discussed. Now, unicortical or bicortical. I prefer to do bicortical in most patients. Initially, in my first few years, I used to do unicortical and used to put in 14 mm screws. But for last many years, I'm putting in bicortical screws, and my average screw length is 16 to 18 millimeters. And I always use a 4 mm screw. Now, suppose what if the lateral mass breaks? So we'll discuss that in just a few minutes. So just to revise some tips and tricks, mark all the holes in one line before drilling, because if the screws are not aligned, the rod, putting in the rod becomes a difficult job. Keep starting point slightly medial to the center to avoid breaking the lateral margin of the lateral mass. If you are in the center, or particularly if you go right to the center, there is a risk of damaging the lateral margin of the lateral mass, and then you cannot use that level to put in the screw. So better to perform decortication of facet joint before inserting the screws, as the screw heads may make it more difficult later. And try to use the longest possible screw, and try to get bicortical purchase, particularly in osteoporotic spines. So if you use a longer screw like 16 or 18 screw and you have a bicortical purchase, that will increase the strength in the construct significantly. And always use counter torque while final tightening the screw, otherwise you can break the lateral mass. So now here, these are two diagrams showing that if you go far to beyond the opposite anterior cortex, you can damage the nerve. And if you go straight ahead, you can damage the vertebral artery. Now, this is one patient I saw recently. He had come to me with neck pain and had been operated elsewhere. And now you can see the direction of the screws. So if there is any doubt, then you should use the X-ray for guidance, or the simplest guidance would be you put in a dissector in the joint space, and that direction should be the angle of your screws. So while troubleshooting, suppose if you damage the lateral mass, what would you do? So this was a 55-year-old male who had a C5 to C7 OPLL. So I did a C5-6-7 laminectomy, put in C5-6 lateral mass and C7 vertical screws. But I broke the lateral mass on the right side, so I extended it by 1 more level above. The problem would be that you are losing 1 extra motion segment. But if the level is in between the construct, you can leave it. But if it is either at the cranial or caudal end of the construct, then you may have to add another level. I'll just show you a few examples where we have done the procedure. This was a patient with 3 long segment OPLL with significant kyphosis. So I did a 3-level corpectomy, and normally if 1 or 2 level corpectomy, I don't go posterior also, but in 3-level corpectomy, I'm always worried about the stability of the construct. So I added posterior lateral mass fixation also. Again, this was a patient who had a previous anterior surgery and had significant myelopathy and progressive spastic paresis. So we did a posterior decompression and lateral mass fixation. Again, another patient with OPLL. So this was a patient who had significant kyphosis and multi-level spondylotic myelopathy. And the surgeon did only a single level corpectomy, and you can see the implant. So he came to us with this. And so this was the post-op MRI. So there was significant compression still, and patient was significantly quadriplegic and was bedridden. So we did a lateral mass fixation, did a laminectomy at 3 levels, and did a lateral mass fixation, and patient had a pretty good recovery. Again, this was another patient with multi-level spondylotic myelopathy. Now a brief about cervical pedicle screws. So I'll start with C7 pedicle screws, which we do often. It can be done either freehand or navigation can be used. I do both. Many times I do freehand, but if the pedicle size is small, sometimes I use navigation also. So for freehand, you perform a small laminectomy like here at the junction of the 2 laminas, so that you can see you can feel the medial border of the C7 pedicle. And once you have seen the pedicle, you can mark out your entry point. You know that where is the medial border, and you can breach it. You can see the superior inferior border also. That will visually guide you to the direction of the pedicle that you have to take. So this is just what I just said. And again, the starting point is created with a high-speed burr. And then initially the drill is set to, the average screw length would be 24 to 28 millimeters. So initially the drill is set to 20 millimeters and then increase in 2 millimeter increments till the anterior cortex is found. So the cranial caudal trajectory is perpendicular to the C7 superior facet, and the typical angle is 15 to 20 degrees medial. And the screw, one can measure the screw length depending upon the ball probe, and you can measure the length. So here I'll show a few examples where we had to do that. So this was a patient who had a cervical OPLL and underwent a C4-5 corpectomy. 3 months later, a routine X-ray showed a subsidence of the implant as the bones were quite osteoporotic. So we went from behind and did C4, 5, 6 lateral mass and C7 pedicle screw fixation. And this has been now 5 years and the patient is quite stable. This is another gentleman. He was an 83-year-old guy who had a significant anterior spondylotic myelopathy at C5 to C7 levels. We did a C6 corpectomy and fixation. 6 weeks later, he comes back with pus pouring out of the wound, and he heard a click sound in his neck. That's when he came. And X-ray showed that the implant had completely dislodged and the bone was quite destroyed. And even C5, where the screws were, that was partly destroyed. And this was my only infection in cervical spine ever. I was really worried about the guy. So we debrided the wound, and I used stimulant granules, which are antibiotic soaked, so which continue to release antibiotic there for 4 to 6 weeks. And after six weeks, they disappear. So we debrided the wound, put the patient in halo for 3 months, and then we did a posterior fixation and C5, 4, 5, 6 lateral mass and C7 pedicle screw. Again, this was a 65-year-old female who was operated in 2 separate countries, and actually my one was in one moderator's country and the other was in the other moderator's country. So in the first surgery, a C5-6 and C6-7 discectomy was done, after which she had a complete collapse of C6 bone, after which this corpectomy was done and the cage and plate was fixed. And as you can see, the screws are into the disc space and the plate is quite tilted, and the surgeon just put in 1 screw here. I don't know what was happening. And so this just shows the importance of taking an AP X-ray also, so that you don't land up in this situation. And the patient presented with significant weakness in both upper limbs, and she had a significant recurrential laryngeal nerve paresis and was recovering from that and had persistent dysphagia. So I was scared to go anteriorly. Otherwise, that would have been the normal approach. So we went from behind, did C5, 6, 7 decompression and lateral mass and pedicle screws. Again, these are a couple of patients with tumors. So this was a patient with metastasis from thyroid. There was significant anterior disease. You can see the vertebral arteries encased. We did a radical job anteriorly, did a 2-level corpectomy, and then put in a cage. But in metastasis, I'm always worried. So I usually do a 360-degree fusion. So we did 4, 5, 6 lateral mass and C7 pedicle screws. Again, this was a 51-year-old doctor with ankylosing spondylitis. It was operated by my colleague, Dr. Rana. And so he had a 3-level lateral mass and C7 and D1 pedicle screws. And you can see here the 2 screw heads are quite close to each other. Sometimes it becomes very difficult to put in C6 screw in some patients. Again, this was a patient with 2-level metastasis. So I did an anterior corpectomy and fixation and then cervicodorsal fixation. Now, a couple of slides on C3 to C6 pedicle screws. I have no personal experience because for me, lateral mass screws are sufficient. I never needed to revise them. And C3 to C6 pedicle screws, as Yousuf mentioned, they can produce a significant risk, but there are several surgeons who routinely do that and it can be done. As the pedicles are small and margin of error is very little, it is preferable to use navigation. Average width of the pedicle is 5 to 6 millimeters, height is about 6 millimeters. So the entry point is just below the facet joint, halfway between medial and lateral facet lines. And as Yousuf mentioned, the angulation here is quite steep. It's a 45-degree angulation almost, as compared to C7, where the angulation is about 20 degrees. So the trajectory is roughly perpendicular to the axis of the posterior elements. So this is a challenging situation, but sometimes but one should know about it because there might be an occasional case where one may have to use it. So this is the angulation that you can see. So with that, I will finish my talk. Thank you for listening to me.
Thank you, Sandeep. A very nice presentation. I think we can make some discussion because the subjects are somewhat different than the others. There is one question for you. What is the size of the screws, the length and the diameter, Sandeep?
I normally use 4 millimeters in almost all patients, and length in females, sometimes I have to use shorter screws like 14 or 16, but in males, I normally use 16 or 18. Occasionally, I have, in some patients with big spines, I use 20 millimeter also.
Do you try to be bicortical?
Yes.
You do.
Yeah.
So then 14 millimeter length is mostly short, and
yes.
you'll prefer 16 or 18, huh?
Yes, but in some females, even at 14, you can be bicortical. In some small spines particularly.
Okay.
But
good.
in adult males, usually it is 16 or 18 millimeters.
Good. There's one person who want to ask orally, I think, Dr. Siyaful Sanin. Please unmute yourself and you can ask question. Okay, he's not answering.
I can read the question. There is one by Gibran, and
you can unmute Gibran. Gibran can ask the question. Gibran, please ask the questions yourself. Yeah, thank you.
Thank you for such a nice presentation and showing us your amazing videos. I had a question about long posterior constructs. So, for example, in cervical degenerative disease, when we have to do a multi-level laminectomy and perform fusion over a large number of levels, such as 5 or 6 levels, do you think it would be biomechanically feasible to skip putting screws in 1 or 2 intervening levels? So, for example, if we're putting screws from C2 till C6, do you think it might be appropriate to not put screws in C5 or C3?
Yeah, one can do that if the bone quality is good, but if the bone is osteoporotic, you will get a better purchase with more screws. Occasionally, we still do that just to reduce the cost to the patient. Occasionally, we skip 1 or 2 levels. But like as I showed in one X-ray, sometimes when you're doing both C5, 6, 7, occasionally it becomes difficult to put screw in C6 because the screw heads at C5 and 7 may be touching each other. In that case, you can skip it.
What about if you wish to lengthen your lower level to thoracic spine? Do you use different rod diameters?
Yeah, so we use a tapered rod in which the upper end is narrow for this. It is 3.5 mm. I think it is 3.5 mm, and the lower part is 5.5 millimeters.
Good. And you have the connectors for that rods, do you?
Yeah, we have connector, but most of the time you can still put in the rod directly.
These are tapering rods, Mehmet. So
Yeah,
there's,
this is a
it's,
tapered rod. Yeah.
Tapered
So it's-
rods. Good.
Yeah.
Okay.
there's another question, Mehmet, if you can read that.
Any
Salvage.
special medication that you give for those patients to prevent screw loosening after surgery? Is there any medication?
Not really, but if the patient is severely osteoporotic, then we treat his osteoporosis.
And one other question, how do you manage vertebral artery injury? What is your experience?
Oh, luckily we never had any, at least in lateral mass fixation. Occasionally in tumors, you do have that, but I've never had it in lateral mass fixation.
Do you
Mehmet,
have
there's
any
sorry, go on.
salvage techniques, such as transfacetal screwing or translaminar? I can add question.
Translaminar would be easy in C2.
Transfacetal.
Yeah, but I have no experience of transfacetal.
Okay. But in fact, there is some salvage techniques for cervicothoracic junction, actually. You can use lateral screws going to the transverse process of T1, for instance, and laterally to the rib. There is, or you can use T1 laminar screws, translaminar screws. What else? I think those are all questions.
There's
Just a
one
question
question,
about
the use of
laminoplasty.
laminoplasty. Yeah, so it's a great option. But particularly if the spine's a bit kyphotic or a patient has significant neck pain, then I generally tend to do more often laminectomy and lateral mass fixation. So my ratio would be 80:20. And particularly if there is a lot of neck pain, then I prefer to fuse the joint rather than do a laminoplasty.
Agree.
Yeah.
I think maybe if you're thinking of a deformity, then you probably need to come anterior. Better off with that. You can take knock off neck pain as well.
There's one more question. In bilateral facet dislocation, do you go posterior?
Yeah, of course, we start with posterior, and many times you may have to go both anterior and posterior.
Yeah. I will comment on the pedicle screws. Actually, pedicle screws are better if you want to correct any deformity. Because lateral mass screws, we must call them as semi-rigid systems, because the lateral mass is not that much powerful as the pedicle screws. However, pedicle screw is hard to achieve, and you must go you must start your screw driver from very lateral. 45-degree is quite difficult. So you may need to make another incision on the lateral part of the primary incision. But if you wish to correct a kyphosis, pedicle screws are better.
Mehmet, may I say just a word about
please.
lateral mass strength? So in my practice, I usually go with the so-called modified Magaro trajectory, which is I start my entry in the lower medial quadrant, and like that gives me a 2 millimeters. So I can routinely put at least 16 or 18 millimeter screws when I go bicortical. So that's having my pull-out strength.
Agree. I do the same. Yeah.
Yeah, I also agree what Sandeep is doing. He first places the lateral mass screws, then make the laminectomy, and then place the rods at the end. You place the rods after the laminectomy, do you, Sandeep?
No. I place at least one rod before the laminectomy, and sometimes both. I want the spine to be stable when I'm doing the laminectomy.
Yeah. Actually, I place both rods after laminectomy. Thanks a lot. I think we can we can finish this session and then come to the next speaker. Dr. Salman Sharif will present us ACDF and corpectomy anterior surgery.
Can you all see that?
Yeah.
Yes.
Brilliant. Thank you, Mehmet. First of all, I'd like to thank Mehmet, Nikolay, Sandeep, and Ruli for putting up another show of how I do it. These are series of talks that we are getting together and talking about different areas. So from here, we're going to move on to another one. And I'm sure the details will be given to you later by either Nikolay or Mehmet. So I will be talking about anterior cervical disc surgery. I also want to thank Saud for his ever glamorous introduction, as always, that he does. I'm grateful for that. Well, anterior cervical surgery goals are decompression of the cord, nerve root, stabilization. Indications are degenerative trauma, tumor, and infection. And this, you have already seen the slide. The important thing to remember is then when you're doing routine anterior cervical disc, we come in medial to the carotid and all the way inside. And it's a very simple, straightforward procedure, and it hardly takes 5 minutes to get inside. Again, if you see where we come from, so if you look at this, that we have sternothyroid and sternohyoid there, and we come lateral to that, and we go through the pretracheal fascia after crossing the deep cervical fascia and cutting the platysma as well before that. And you've got the anterior retrovertebral fascia that you need to take as well before going on to where you want to be. So types of surgeries are shown here, and I'm going to go into details of that. What is the advantage of anterior surgery? Obviously, it can address most pathology, allows direct decompression, and it's good for all posture, kyphotic, straight, lordotic. It works very well. Very simple, straightforward procedure, causes minimal pain. It's well tolerated. You can put in a graft if you want to fuse. If you don't want to fuse, that's okay as well in some cases. It follows tissue planes. There is no muscle dissection, so that's why you don't have any pain, and that's why the risk of infection is less than 1 in 600 in routine series. There's less risk of infection than posterior. Posterior, we're cutting all the muscles coming inside. So there are multiple risk factors involved if you do a posterior approach. This has already been discussed by Yousuf. So hyoid bone is C3, angle of mandible is C2. And if you see that C4-5 disc is at the level of thyroid and C6 at the level of the cricothyroid. Muscles have already been discussed. I'm again going to stress that underneath the longus colli, 2 to 3 millimeters underneath that, we have the sympathetic chain running, and you need to be careful when you are dissecting using bipolar or monopolar. If you're using bipolar, you need to keep it at minimum strength, and if you're using monopolar, same goes. So you need to keep it less than 15 hertz if at all possible, because you don't want to be burning those sympathetics underneath and causing Horner syndrome, although you may have done a brilliant procedure. This is already shown, and the most important thing from our aspect is that the recurrent laryngeal nerve, because you can have a problem with recurrent laryngeal in 2 to 3% of cases. So this folds underneath the arch over here. On the other side, it folds underneath the subclavian. So you can see that if you're coming on the right side at C5, C6, you may be seeing the recurrent laryngeal nerve at this space. So as long as you have blunt dissection and you don't cut anything that looks like a nerve, then you'll be all right. This is another important thing that Yousuf had mentioned, that vertebral artery generally enters the foramen transtrocerium in 90% of cases at C6, and 7% at C5, and 3% at C7. You need to be wary of that if you're planning any surgery in which the foramen is involved, and because there is about 3% aberrant course of the vertebral artery. This, again, I can't stress more about the recurrent laryngeal. So here, what I've done is I've dimmed all the other nerves and shown you the two recurrent, and just to show that what is the difference between the two. So this is going across on the C5 level, whereas this recurrent laryngeal nerve is all the way underneath over here, going where the vesicle going underneath the nerve and coming around it. So you need to be wary about that. Recurrent laryngeal on this side is this high up, and on the other side is much lower. We talked about the stellate ganglion and the sympathetic chain. So that's the sympathetic chain. So you can see the inferior, middle, and the stellate ganglion on top, all the three, and they run underneath the longus colli. So you need to be careful about this. Sorry, not going to show you this video, so I don't have enough time. And anatomy has already been discussed. Horner syndrome, this picture was again shown by Yousuf before, so I'm going to skip this. How do we do this? Obviously, both sides are okay. You can identify the level with a C-arm. You have a skin incision. Obviously, majority of the time that a skin incision is transverse. And we can go up to 3, even 4 levels sometimes of the transverse incision. I usually go up to 4 levels with a single transverse incision. But if there is a gap in between and I want to do above and below, I could have skipped discectomy, 2 transverse incision. If, for example, if I'm doing C3-4 and C6-7, so I would do 2 transverse incision. Vertical incision, I would only use if I'm doing 2, 3 level corpectomies, or if I feel that I need to do many more levels than I require. I prefer doing spondylotic myelopathy patient from anterior than posterior generally, because I think I can give much better results with that. Obviously, the landmarks have already been discussed. Sorry, Imad, if you could take up all these people who are trying to come in, if you could just enter them so I don't have to do that. Thank you. So this we have already talked about. Angle of mandible is C2-3, hyoid bone is C3-4, thyroid cartilage is C4-5, cricoid is C6, and supraclavicular groove all the way down here is C71. But we always confirm with X-ray. Once you have given skin incision, what I do is I put in a self-retaining retractor, give it to my assistant to lift it up slightly. So the platysma is slightly lifted up. And I use a knife to cut that in the same plane. Some people open it in vertical plane. There is no difference in outcome. And from then on, there's a blunt dissection. And then you just need to go through those 3 facial layers that I talked about. These are the 3 facial layers that we talked about. So once you have opened the platysma, so you need to take the deep cervical fascia. This can be opened with sharp dissection, and this easily opens up with your blunt finger dissection. Once you come down here, you have to lift it up with some kind of an instrument, and then cut it with scissors before coming onto the vertebra. And the important thing to understand is that you should have the esophagus on the other side underneath your retractor. So your assistant retractor should have that. I usually lift the retractor and make sure I can see the esophagus. I've had the pleasure of giving an incision in esophagus once as I turned around to get an instrument, and my assistant had given way. So now it's been 10 years and I cannot forget that. So sharp and blunt dissection, as we talked about, and you put in your finger and you make sure you feel the carotid on your lateral aspect, and then you dissect and feel the bone all the way down. And generally you feel osteophyte in these patients. What you do is you confirm the level. You open the prevertebral fascia, as I said, and then on both sides, you elevate the longus colli muscle. And this can be done with a bovie or with a bipolar, whatever suits you. As long as you need to make sure you're not touching the retractor with your bovie or the esophagus. Otherwise, if you make a hole, then you would be that 1% out of 600 who's going to have infection there, as well as food leaking in. And then you place your retractors. We generally put sharp prongs on the lateral side and the blunt prongs above and below. And the idea is that they stay underneath the longus so that the retractor does not move. Then you can put in a retractor and do your surgery. I generally don't use this retractor because what I found was when we use this, usually people have dorsal neck pain or nape neck pain for a few weeks, and I don't like that. Then obviously you remove the disc by giving an incision, and we will see the case later on. You remove and if whatever osteophytes you have anteriorly, you have to clear before putting in your retractor. That is important, otherwise your retractor will not hold in there. So all those anterior osteophytes need to be removed at that time. And then you remove all the disc, you remove the posterior annulus, and there's a trick of taking it out. And you need to inspect underneath that, make sure there is no disc. Yesterday, I was doing a large disc prolapse in which there was so much of disc underneath in a young doctor. And then you resect the discovertebral and uncovertebral spurs, which Yousuf talked about and showed earlier. So this is, you can do earlier at the earlier phase of the surgery. And once you're underneath, you've taken the disc, you can use a match head or a diamond drill to remove this, and then end up taking out the bones onto side underneath that with the help of 1 millimeter or 2 millimeter punches. The important thing to remember in all this, never forget, once you get to the stage of the PLL or getting to that stage, you need to have the mean arterial pressure where you want it to be. That is, and you want to get that map around 80, 85. And if you do that, no matter how tight the canal is, you will not have problem. But if you don't worry about your blood pressure, not your blood pressure, patient's blood pressure, then you can have serious issues with the outcome. So keep looking, because anesthetists are not bothered what's happening, and they need to be reminded again and again. So some of them are very good, but some will give you trouble. So you need to be wary what the pressure is. Decompression is done with caution, as we just shown there, and unconvertible joint underneath the spur is also taken. When you're doing corpectomy, I generally do a discectomy on both sides. Then if I need the bone, then I would use a nibbler to take that bit of bone. If I don't need the bone, I can use a big match head or a cutting burr to decompress. Once I'm coming to the cortex, I use the diamond to remove whatever I need to remove. It's OPLL. I generally take all of it. Even if if it's really stuck, I would leave a part floating. Once I've done that, we talk about plating. This is very important. That majority of the plates we have are dynamic plates, and these dynamic plates will sag. So you don't want to be putting a straight screw. So if at all possible, your plate has to be as short as possible to the edge. So it should not be coming onto the other side, because if there's an osteophyte here and your plate, once it sags, goes into the osteophyte, then you will have an adjacent segment disease. And that's not because of the patient problem. It was because the way you did surgery. Also, you should not stick in needle into the disc space if you're not sure, because you're going to damage that disc above or below if you're not sure which level you're in. Your direction of the screws have to be away from the plate. So superior one is going to go superior, inferior one is going to go inferior. And lateral, so that in case if you're in a dangerous situation, then you can, medial. And if you're in a dangerous situation, if your plate is not in appropriate place, so you will be going away from the vertebral artery. So in order to avoid that injury. So it's very, very, very important. So for example, if you see these screws were put in straight, and they have fused, but this would be the ideal trajectory that you need to be coming. So you can see once the plate sags, this is what it does to you. So it's going to cause problems, and you can see the halos start to appear in these. And this is not the best way to put in these plates. So biomechanically, stability due to bone graft and not due to the plate itself. The bone graft has to be good. So whatever you put in, chips or whatever inside a cage or a bone graft itself is fine. And you need to widen the neural foramen, as we talked about. So if patient is lordotic, you can do a simple discectomy, and some of my friends do simple discectomy and they can get away with it. I generally do not do this discectomy, because majority of the patients come to me after a while of their symptoms. The doctor that I did yesterday had only symptoms for 6 weeks, but had huge osteophyte underneath as well. So there was some problem going on for some time. So all that is very important. If you have severe neck pain, ACDF is much better. If less than 4 millimeter, you might get away with simple discectomy. With more than 4 millimeter, ACDF is better option. So with TDR, I think Nikolay Peev is going to show some pictures regarding that. Corpectomy, if you're doing a big level corpectomy, you need to put in screws in between to make sure you bring the bone to the plate itself. I will show some pictures of anterior foraminotomy that I think I borrowed from Mehmet ages ago. This is anterior approach to the lateral 1/3 of the vertebral unit. So direct nerve compression by excision of uncovertebral spur and protruded disc vertebral via foraminotomy and uncinate process. So I've done about 5 of these, and it's been over 5 years, and I haven't had those patients coming back. So this is one way of addressing a problem as well. We want to make sure that you don't disrupt the disc. I do take part of the disc on the lateral aspect, but I didn't find any problem with these discs over all this time. So basically, once you have gone in, put in your retractor, you have a retractor underneath, and as you drill part of this bone here, and then slide in your retractor, and then you can drill all the way down here and can take that spur and decompress. So you can see this is how at the end, what you do is you leave this bit of bone at the end, and you just lift it with a hook. And these are the results of this patient. What about the complications? Obviously, adjacent tissue organs can be damaged. Graft material can cause problems. Hematoma can happen. Infection is very, very rare unless we cause problems with esophagus. Donor site, we do not use these days because of the problem with donor site problem in about 20% of these patients. And you can see the figures could be really, really mind-boggling, but we need to be careful. In this, we have not included the weakness that you could get in about C5 and C6 patients following this surgery if you do too much traction or you manipulate the nerve too much. You don't want to be going and pushing on it. You should be rubbing side to side. That's how you should be doing it. You should not be pushing on the bone onto the cord itself, because you don't want to be causing problems. And using the diamond burr, old fashioned, if you want to be putting in a bone graft, you need to be careful. You don't use the bone tap on top, because if you do that, you can cause problems. Same can happen for the cages, and you need to be careful that you understand how your cage system works. You don't want to be pushing into the cord itself. Vertebral artery injury, it can happen if you're not careful. How I know that I have done enough decompression? What I do is I use a hook underneath, and I will show you in the video that we have. So this is a 45-year-old female with neck pain radiating to left arm for 3 months with numbness and hand weakness. And these are her x-rays, and it does show that level to be coming closer. This is her MRI showing the disc. Sorry, I'm going to stop here because unfortunately, majority of the time we bring the microscope in once we are on the disc. Same was the case here. And you can see this is the two lateral sides. This is superior and inferior. And what we have is longus coli on both sides dissected, and underneath, the prongs are underneath, so it's static. And you can see that esophagus on that side, and we have the carotid on our side, so we keep it lateral. I generally stand from the right side, so right-sided surgeons generally do it from the right, left do it from the left. But if you're not using a microscope, then probably you're better off coming to the opposite side if you're using a headlight, because you automatically decompress your opposite side better. And then once you have come in here, you identify, take down all those osteophytes, put in your retractor, clean up the bone on both sides, and then you have a ledge of bone on top of the disc. So you take that initially with 1 millimeter, and then 2 and 3 millimeter punches, and remove that ledge so you can see whole of the disc space cleanly. Then you give incision, take the disc out as we're showing here, and then you use curettes, and you curette the end plates on both sides. You clear out the anterior vertebral body completely. I use a diamond burr to make a hole in the underneath. Use a hook. This is the hook going underneath the PLL. And what I do is then I turn the hook around, bring it out. So to make space, then use a 1 millimeter punch to open that space, and then go on both sides and clear the whole thing out on both sides. Once you have done that, you apply a trial, and then proper size peak cage with the bone inside is going inside. So that's the cage in, and then use the plate. And again, you see the screws are going away and medial in cervical spine always. And if you can have a post-op x-ray, and you can see your screws going away, and this is so important in all our cases. So this is another patient that I did only a few days ago. So position, neck is extended, depending on what level you're doing. Shoulders are retracted with some kind of a tape. So if you want to see a lower level, via ETG goes underneath the bed. So it comes around and goes underneath. So you don't want to be damaging any of, don't want to be your assistant, don't want to be pushing on that endotracheal tube. You check the level first, make sure it's the right level. And I'll just show you, we give an incision. And what we do is, one second. What we do is we open up, this is how I cut the platysma. So it's by lifting the prongs which are underneath. And then blunt dissection, opening it up. And confirm what level it is. And this is how we do this. This is actually another case. with a fracture as well as a disc prolapse, and so this disc is coming out and part of the fracture has already been removed. And using a curettage, that bone that had gone inside is being removed, and you use a diamond drill to open up, take out the end plates, and the cage goes in, and a bit of osteophyte that's anteriorly is cleaned as well. And again, plate goes in, simple, straightforward procedure, same way, same screws goes the same way every time. And these are the retractor systems that we generally use. So I thank you, everybody. It was a pleasure to be part of this webinar. Thank you, everybody.
Thank you, Sandeep. Very nice lecture. I want to remind the participants that the left-sided approach or right-sided approach does not differ much for postoperative dysphagia. There are very nice studies showing that. But if your surgery is very long and you place your retractors for long periods without releasing them, the retractor blade and between retractor blade and the trachea, the nerve squeezes, and that causes the postoperative recurrent nerve palsy. For that reason, you can ask anesthetist to deflate its cuff, or you can remove your retractor blade for a time during long surgeries to prevent that.
Mehmet, I was hoping somebody would ask it. You asked this question, that's why I didn't tell them. So you already answered that question.
I just answered.
That's good.
There are some questions. One is that please suggest best approach for C2, C3.
I think, it's easy to come anteriorly as well. It's very simple, straightforward. The thing to remember for upper cervical spine, so people who are above the age of 75 or people with comorbidities, if you operate the upper levels, then you need to be careful because, for example, C3-4, C4-5, long retraction will lead to dysphagia, as Mehmet just talked about. C2-3 actually is quite simple and it's very easy. The important thing to remember when I'm doing upper levels, what I do is I put in a small tape across the neck and just put a little bit of traction, and I can easily get into C2-3 space without any problem. So I plan this beforehand when I'm doing these.
The mandible edge will prevent you to see better, but if you make an anterolateral incision, the so-called anterolateral retropharyngeal approach, you can easily come over there at the C2-3 level. But your corridor is very deep, and then it's not good for big masses or big problems. It's good for small tumors or small approaches. How is the uncovertebral joint decompressed during ACDF to free the nerve root? One question.
I think I just explained that what we do is we once you've taken the disc out, we go all the way laterally. And once you've gone all the way laterally, then we use a hook to see, have we done a proper decompression? So you should be able to hit the pedicle on that side. And then underneath the nerve root is going. So you check that as well. And you've got 1 millimeter punch to remove that pressure, or you can use a small diamond burr to free that. And it's done routinely in every case. And the reason being that, especially in cases when we see the osteophyte on top.
One comment from my side about that. Obviously, the biggest worry is you don't want to go, you're afraid, especially if you're a junior surgeon, you're afraid to go laterally and decompress the nerve because you're afraid to hit the vertebral artery. This is actually, if the vertebral artery has a normal course, it is very difficult to do that. So you can be brave and go laterally. As soon as you have seen your MRI scan preoperatively and you have seen that your vertebral artery has a normal course, I was reading an article recently, which is a good article on vertebral artery injury. And so everybody knows that the riskiest procedure is C1, C2 screws for injuring vertebral artery. But these guys, they produced a lot of cases. And so it appeared that the second and not so far behind is the vertebral artery injury in corpectomy cases because of this anomalous course of the vertebral artery. So you check your MRI scan before you do corpectomy or even ACDF because there is such thing as kissing vertebral arteries. They go inwards sometimes and they can surprise you badly. So this is when the vertebral artery.
One comment on that uncovertible joint resection. Actually, if you are making a decompressive surgery, it's not necessary to remove the uncovertible joint. But if you wish to make an anterior osteotomy, so then you must remove the uncovertible joint on both sides. So without that, an anterior osteotomy is not possible. So you will be dealing with vertebral artery on both sides, or you'll be very close to the artery. You must, as Nikolay said, you must then have a good preoperative CT angio to see if there is any anomaly.
I think
but uncovertible joint resection is not our routine.
no,
Only in osteotomy cases.
Yeah, that's we don't take the uncovertible joint. It's the spur we are talking about, which forms underneath and cause problems. So, I do about 5 of these every week for a long time, and I haven't seen a single vertebral artery injury, touch wood. But having said that, you need to be careful. You need to look at the images beforehand, as Nikolay said. And if the spur is there, you need to decompress it. Otherwise, the pain will continue.
Question, what is your opinion on the standalone technique of dyschromia and cage without plate?
Yeah, there are there are a lot of standalone instrumentations available, and they work very well in some people's hand. I rarely use standalone, maybe once every 6 months or something, and it's not my favorite thing to use. Yes, it may work in the long run once we have good results. The problem with some of these are there are only 2 screws. Some of them have 4 screws to hold it. And then there are some that you put in a cage alone. Cage alone is okay in old days, but nowadays we need to be careful that we want to make sure that it doesn't ever come out. And for that, maybe plate is, these excellent plates have got excellent results. So there's no point in changing that.
One question, problem of C71 level. How do you manage to see with the C-arm?
Generally, you can once you pull the shoulders well, but if you can't, then you can use an AP approach. That is possible, or you can have an image on the table with a tilted C-arm. And that's possible.
Yeah. The question is, will age of the patient affect decision of anterior or posterior?
Yes, if somebody is comorbid, somebody 80 years of age, and I have to do for example, a 3-level decompression with OPLL, then you're better off coming posteriorly. Having said that, I feel that I can give better results anteriorly, so I try, if at all possible, to do all these cases anteriorly. But age above 80 is known to cause significant dysphagia for a long time, and if you give this to a person 80 plus, then you are going to reduce their life expectancy.
Another question, the nasogastric tube, it can be helpful to avoid esophagus injury.
Yeah, so any recurrent or redo surgery that I do, I always put in an NG tube inside. I want to feel it. I want to make sure, because there may be scar. So you just need to be careful. And if the previous person 20 years ago had made a hole or something in the esophagus and had caused problems, so you need to be careful. So I always put an NG tube in cases in which there is either deformity or a recurrent problem.
The question is, what do you suggest about artificial disc replacement?
I think we can leave it to Nikolay, since he'll be showing some of his tricks shortly.
Okay.
So can I make a comment? Uh, so I have stopped using plates for cervical disc for last 5-6 years, and I just use standalone cages, and I have not seen a single cage coming out, and had pretty good fusion rates. I don't think it really makes any difference.
Okay.
I'm with Sandeep here.
And artificial disc, I use them quite a lot in young patients, and they are excellent.
So we let Sandeep tell us.
I love it.
I think it's time for Nikolay to tell us about cervical artificial disc replacement.
Okay, thank you. Let me just switch my presentation and share with you. Do you see it?
Yes.
Okay. Okay, so I'm going to talk to you a little bit about the cervical arthroplasty. So surgical approach, everything is literally one-to-one to what it was already said by Salman. Absolutely similar approach. If you do ACDF or if you do disc arthroplasty, you can see on my screen I have done actually a hybrid solution. Lately, I do quite a lot of this as well because the different discs would be in a different stage of the generation, and then you can use at one level ACDF if the disc is very degenerated, and on the other level you can do disc arthroplasty. So this is how it started. The first disc was designed actually in Bristol in UK and in 1998, and then after this there is an avalanche of new devices which had been introduced, and they've been trialed and they are surveyed. So now we have first generation, second generation is now launched as well, and we have many options with that respect. So why we should bother with cervical disc replacement? What we have to do with the surgery is we have to try to restore the sagittal alignment in case it's distorted. We have to achieve or restore mechanical stability in case we have problems with that. Restoration of the motion segment. Obviously, this is something that is not going with the mechanical stability. If you have instability, obviously, you would not choose disc replacement. But if you have, as Sandeep said, young people, then the disc replacement could be a good option. And why is that? Because of this research and this paper that everybody quotes, talking about disc replacement, 2.9 per year and 25 for 10 years % of adjacent segment disease. This is something that we are all trying to prevent by using disc replacement techniques and devices. So indications for disc replacement, you have to have a mobile motion segment. That's why you choose young people, because if you have over 65 patients, and especially over 75, it is very unlikely to have a disc that is mobile. My cutoff is 65, but some people go above that. I've read one article from the States where they were doing disc replacement over 85. I don't understand that. A restoration of the, you have to have soft disc herniation. If you have severely ossified posterior longitudinal ligaments, then you would not go for a disc replacement. You will go for the standard ACDF. One of the goals, of course, is decompression of the spinal cord and mostly the spinal nerves. Usually, if you are trying to do disc replacement over simple ACDF, you have to also consider how many levels you are doing, or you can use hybrid options I have mentioned already. Contraindications, as I said, if you have more than 3 levels, in my practice, I would not go for pure disc replacement. I might consider hybrids. Osteoporosis, I would not do disc replacement in case I I have to deal with osteoporotic patients, severely ossified posterior longitudinal ligament. If there is a severe kyphotic deformity, in trauma, I would not do, and if there is infection, I would not consider. The surgical procedure is standard as with the ACDF. You have to develop the same approach. You have to remove the disc in the same way. You have to remove the PLL. And usually you should keep the skin, the midline. You have to have a marker for the midline. In that respect, I usually, when I do my skin incision, I tend to surpass the midline with the skin cuts, usually with about 1 centimeter. And like that, I have found that the skin and the structures are not pushing me so much contralaterally, and like that, I am easier to keep the midline under just where it is and to keep an eye on the midline. You have to remove anterior osteophytes in case any. Salman already emphasized the importance of that. And when you're cleaning the end plates, you have to clean them well, but you should try not to breach the end plates, not to break the end plates, because if that happens, then obviously you will be at risk of ossification there. So some pitfalls: do not over distract. This was emphasized already. If you're over distracting, you may have significant postoperative pain. You have to choose your footprint properly, because otherwise you are risking subsidence of the implant or compressing of the structures. You have to try to center the implant very well. This is more valid for the old implants, like the ones which I have on my slide here. With the new generation implants, keeping the midline exactly just in the middle of your cage. And if you slightly rotate your cage, that will not be as big as problem as with these old first generation devices. I will show you a cage like that later on. So what are the pros and cons of the disc replacement over ACDF? So if we are talking about disc replacement, you have a motion restoration technique. You are reducing the adjacent segment disease. There is a lot of literature. Now we have 5, 7, 8 years follow-ups of different devices, and we have good proof that this is happening. The adjacent segment disease is reduced. There is no risk of pseudoarthrosis. With the ACDF, you have better leverage to restore sagittal alignment. You can go for many levels, and in general, you have wider indications with ACDF, and with the TDR, you have to be a bit more selective. If we are discussing the cons, no sagittal alignment. Again, indications are young people with mobile disc. You are risking heterotopic ossification, and in some cases you can have implant wear, but with the modern devices, they are tested for a million cycles, and this is something that is not happening very often. With the ACDF, you have adjacent segment disease, which is higher. Pseudoarthrosis can be one of your problems. That's what we were discussing just now, for or against plating. And then you may have loss of correction due to different factors like osteoporosis or breaking the end plate and so on. So, as I mentioned, there is a significant body of information now, and good research that suggests that the TDR is reducing effectively the adjacent segment degeneration. Although this is still a debate, there is a lot of researchers which are still they're still not convinced with that. I was reading actually today an article from 2019 from Benzel and collective, and they are still not convinced that the TDR is reducing the adjacent segment disease. However, There is many authors which will accept that, and this replacement is used more and more, especially with the young population. So it is safe procedure. Now we have this replacement devices in use more than 20 years, and we know that the safety profile of these devices is at least as good as with the ACDF devices. So you should not be afraid to use them, having on mind proper indications. Heterotopic ossification, as I mentioned, is a problem that you have to be mindful about. You can see, as per this publication, the heterotopic ossification varies from 9% up to 18%. In different publications, the researchers are linking that to inappropriate posterior longitudinal ligament clearance, using of the cautery, or inappropriate preparation of the end plates. It happens, and it will happen, but with the new devices, that percentage, I believe, is less, and also depends on your surgical technique, of course. So one of the main points of criticism of the disc replacement devices is that they do not mimic appropriately the movement of the cervical spine segments. You can see on that slide that diagram is showing you the way how the segments are movement. The movement in the segment is happening not around an axis, but around the centroid, because the cervical vertebra motions are coupled. You can see here, usually flexion and extension goes with translation, anterior or posterior, and the lateral bending goes with rotation. You can see here in that table how the movements are coupled in different levels. Unlike that, the ball and socket design devices are not possible to provide this centroid type of movement, but the movement is happening around an axis, and there is no translation because of that, and this is putting more strain to the facet joints, and that gives over-destruction, that gives respectively more degeneration, and then higher chance of ossification problems. This is a good slide that is demonstrating the stress-strain curves. You can see here, this is the stress-strain curve of a normal disc. And you can see with all these dynamic devices that we have nowadays, the stress-strain curve is quite different from the one which is the natural one. However, I would say with the new technology that we are having nowadays, with the new second generation devices which are in use already, this problem is not there anymore. You can see this is one of my cases, and you see that apart from angulation, you have also translation. So this is a problem that does not exist anymore, and we don't have long-term service with these devices as yet. However, I believe that these are ongoing now, and there will be better results with the new devices. And that was it from me. Thank you so much.
Thank you, Nikolay. Ruli is here?
He was there some time ago.
Yeah.
No, don't see him here.
No. There is one question, Nikolay. Is there any difference in result of disc replacement with ACDF dynamic devices?
I'm not sure how to read that question. I see that question. Is there a difference in the results of disc replacement versus other ACDF dynamic devices. I'm not sure what is ACDF dynamic devices.
Basically, all these dynamic plates that we have that have been there for last 5 years, 7 years. All the plates are dynamic.
Oh, the plates. Okay. Well, of course, obviously with the disc, you have better preservation of the motion. There is no plates, even if you do ACDF plus plating, then you will have relatively rigid device, but that will not be 100%. You will not stop the movement in 100%. However, with the disc arthroplasty, you are aiming to restore the movement. So if you compare your patient before and after the surgery, you should have actually more movement in the majority of the cases, or at least same as preoperatively.
Anyway, these dynamic devices don't do anything to the movement. Basically, they are for the subsidence of the graft and to prevent the strain on the screws.
Yeah, if anything, they will stop movement more than they will improve.
The other thing, Nikolay, we looked at Yoakum's place. They looked at long-term results of about 65 patients over 22-year follow-up, and their adjacent segment disease were 2 patients, which was 4.5% over 22 years. So I think we have to be careful with all the companies who come up with different percentages telling us that, no, this is the only way forward. So I think in the long run, there will be better. When I talk to Benzel about this, and when I talk to other people who are into biomechanics, they think the ideal TDR hasn't come out yet. He also brought out 2, but he didn't like them. But he never marketed them. So I think the ideal is somewhere ahead. And heterotopic ossification is a big issue, because I remember a few years ago that some people who started doing went away from it because of that. So I think there are issues.
No, I don't think that is, Salman, I don't think that is a major problem. I recently just saw my first patient whom I had operated almost 17, 18 years ago. And I got his X-ray done just out of curiosity to see what was happening. And he did not have any heterotopic ossification. And I don't recall, until unless my patients went to somebody else, I don't recall a single patient with adjacent segment disease where I have done a total disc.
But I have the same experience. I did my first artificial disc in 2004. And that patient, yes, is doing very well, and it's still mobile. But those are exceptions, and we need to accept that. And yes, you may have very good results for whatever unknown reason, but the results, scientific evidence does not tell us that at the moment. So let's hope that it will
I think a lot of these studies are biased also in favor and against it also. So you have to individually see the results.
So I personally, if I have to say something about that, I have done my first disc replacement in 2008, and I was enthusiastic about that. And then for a couple of years, I got disappointed because I have seen also bad results. And then I remember Professor Zileli had invited me in Spine Masters in Turkey. It was I think in 2015. And he asked me, can you deliver a lecture on a disc replacement? And I have asked him, can I deliver why I don't do disc replacement? And he said, yes. So that's what I have delivered. But then over the last couple of years, I have started doing this again because I have these new 2nd generation devices, which are basically not restricted on a ball and socket mechanism, but they are mobile in all the direction. They allow translation, they allow rotation. Basically, they allow these coupled movements. So, and I've done already probably about 30 of those, and I see my patients being happy, so I'm hopeful that this will give better results. I don't have long-term results, but I'm happy that even if the results are similar as with the old devices, we have now 7 and 8 years follow-ups with the old devices, which show that there is some reduction of the adjacent segment degeneration. Yes, I mentioned that article from Benzel in 2019, and he's still not convinced. But if you speak to Greg Trost, he will tell you that this is a very good technique, and he's very convinced. So I think it's still dealer's choice, but there is now literature supporting that maybe it's good for your patients.
Thank you, Nikolay, for making a very honest history of what we are doing. Actually, there are three concerns of mine. Yeah, one is that they are more expensive. We must pay extra because with ACDF you don't need to pay anything, but with artificial disc you must buy it. Second, they create some artifacts on the postoperative MR images. They always create some. Third is that the difficulty in placing it is technically demanding, the artificial discs. And I believe with the current minimally invasive techniques, you don't need to remove all the disc, and you can make anterior or posterior foramen tomies most of the time. And if there is any deformity, you cannot use artificial discs. So because of that, the indications are quite narrow. I believe this. There is one more question. With the multi-directional movement, do we anticipate negative impact on facet joint due to the movements?
Well, actually, this is what is happening when you have a healthy disc. You have multi-directional movement there. So the idea is to keep that happening, and like that, basically the main point of the proponents of the disc replacement is that if you fuse that level which you're fusing, then the adjacent segment above and below starts moving more. That is giving more trouble to the joint, that is giving more trouble to the disc, and then this is accelerating the degeneration. So preserving some movement is in the index level. It's preserving the adjacent segment by the adjacent segment not having to take all the movement that is normally happening in the index level, which is already fused and it's not moving. I don't know if I was very clear what I said, but so if you fuse it, your index level stops moving, and then the adjacent segment starts moving more, and that is the rationale behind accelerated degeneration. So if you keep some movement in your index level, that's good for your adjacent segment.
But anyway, the body tries to fuse it that level and then make heterotopic ossification. It doesn't matter whether you place a motion preservation technique or not. Do you advise local anesthetic infiltration to relieve pain before skin closure?
No, because it doesn't cause any pain in any of these procedures.
I don't use that in any of my cases. Preoperative lidocaine infusion, I stopped using that because I've asked why we are doing that, and nobody was possible to explain to me. The patient is anesthetized.
Okay. What is clinical difference in symptoms on neurologic deficits in cases of disc replacements versus ACDF?
Difference in clinical symptoms. So it could be similar. The way how you select whether you do, or at least I select whether I do disc replacement or ACDF is mainly if I see, for me, the age of the patient, and not age of the patient as absolute value, but the way how the MRI scan looks on the imaging. If we have a soft, nice disc, then in a young patient, I will go for disc replacement. If the disc is collapsed with a lot of osteophytes, there is no movement, the facet joints are degenerated, then I'll go for a simple ACDF. And then hybrid solution is usually if you have to address 2 or more levels, they are on different stage of degeneration. So this is the rationale behind hybrid solutions. So you choose the most degenerated level, which you would do ACDF. But if there is a disc which is less degenerated, you can do disc replacement, and like that again you shorten the rigid construct. There is a good paper from Mumaneni. They have checked if you fuse one level, then the adjacent segment intradiscal pressure goes up with 50%. If you fuse two levels, it goes with 150%. So this is what they say is why the adjacent segment generation is happening. So this is why I use hybrid as well.
There is one question.
Can I just add? My worry is that, you know, we have got papers coming out now routinely that I'm seeing with artificial disc being used for myelopathy, severe myelopathy. And no matter what age, no matter what the indication, it's like, you know, ozone that was used even for infection and disc and everything. So it's like having a black thread tied to my hand and saying that it will cure the thing. So please, we need to have some scientific basis. And yes, there is certainly evidence that it may be beneficial, but I think we are not yet there. I don't know how you feel about it, Mehmet.
Don't use disc replacement for myelopathy patients.
Yeah.
There are our friends who are using it, and I reviewed a few papers recently.
Yeah.
There is people in UK which are using it, including the guy that I had fellowship with in Manchester.
So let's keep the name to secret.
Yeah, I'm not saying names, but, you know, I'm saying that, you know, I can see that different people are using it. I think it's personal choice.
Okay.
I don't.
Yep. There is one question from Dr. Ahmet Abu Zaid.
Thank you so much. And thank you, Nikolay, for the nice talk. It's been a while since we worked together.
Hi.
Hello there. I have to say, going back to the evidence, when you mentioned the 10%, the 25% risk of adjacent segment in 10 years, I have to say the evidence behind this is not very strong. And the same group that published this original paper in 1990 failed to reproduce the same results in a subsequent paper. And furthermore, this is radiological adjacent segment. This is not true adjacent segment disease, not clinical adjacent segment. This is radiological. So you've got to be a bit careful. I'm not against disc replacement. I still do, I did a big number in 2007 and 2008, and some fused, some didn't. So we had some problems with some of them. But the important thing to stress, it's 25% adjacent segment is not clinical. This is radiological.
I think the ACDF versus ACDR, that question is like now we have the question about the vaccines, whether they work or not. I think that's going to be discussed, or maybe there's been in discussion already for maybe 15 years, probably is going to be for another 15 years. So it's becoming like whether you believe in it or not. So there is believers, disbelievers. I think it's still more or less dealer's choice. There is more and more clinicians which believe in it. As I told you, I did the same. I used it in the beginning of my independent career. Then I stopped, and now again I'm starting to use it. I don't know. I'll tell you maybe in 2 years if I will get disappointed or not. My initial results are promising.
Okay, I think let's come to multiple choice questions, Mehmet. What do you think? You're running late.
There is one more question, I think.
Okay, sure. Shall
we? Very shortly, listening here from the US, your question regarding hybrid ACDF TDR. What is the current best published evidence regarding whether hybrid constructs are viable alternatives to all fusion or all TDR for more than single level constructs?
I think I've answered that question without even being asked. I mentioned that there is publications which are studying the intradiscal pressure, and if you fuse one level, the intradiscal pressure, and if you compare with fusing two levels, the intradiscal pressure on the adjacent segment, which is not fused, goes up times comparing to one level. So this is the rationale behind. There is a good paper from Praveen Mumaneni that they can find. I'm sure if you write hybrid solutions, Praveen Numaneni, it will come up. Sorry, I cannot give you the year and the where it was published.
Good. I think, Nikolay, you can continue with questions.
Okay, so these are the these are the first questions on
Yousuf.
Sorry, Yousuf.
From Yousuf.
On surface marking C2 corresponds with what level? So 82% of the participants are angle of the mandible. Yousuf, are you? Do you agree with
Yousuf,
that?
please unmute yourself. Yousuf.
So he went to the hospital.
Okay, no problem. So this is true. That's okay. That's a majority of them got it right. Next.
Yeah. Recurrent laryngeal. Oh, sorry.
Sorry, it's the second question is above.
What is the maximum safe distance?
We can't hear you, Nikolay.
Can you hear me now?
Yes. Where did you go?
I don't know. What is the maximum safe distance you can go beneath the longest colli muscle? Okay. So the majority of the participants have answered 3.
Please, we can't hear you.
So I don't know.
Yeah, you need to step forward. Yeah.
The majority of the participants have answered 3%. I think they have.
That's right. That's right. That's okay.
That's right. That's okay. Okay, next one. The recurrent laryngeal nerve is more susceptible to injury on which sides? So majority are 65%. Yes, that is the right answer. Okay, during anterior approach, veins can normally be coagulated if required.
Okay.
Yeah, that's okay. Okay, that's right. Uncovertebral joints form which wall of neuroforamen? So
okay. That's fine, medial.
That's right, okay. Which of the following is not a lateral mass insertion technique? 50%.
Sandeep, where is Sandeep gone?
Hello?
Is
Can you hear
Sandeep here? Yes, we can hear you.
No, I am asking him to continue.
Okay.
Okay, so the answer is Abumi. Yeah, that's Abumi is famous for pedicle screws. Okay. Average screw size for lateral mass is screw. So basically, that's the diameter. Yes. Okay, 3.5 to 4 millimeters. Yeah, most of the participants have got it right. Okay. Average length of lateral mass screw is so 50% are responding 16 to 18%. Yeah, yes, this is a good answer.
Well, I think we need to be careful that, what technique are we using? So for the technique that was shown, yes, this is 16 to 18 millimeters.
In my hands, this is the right answer, but as I said, I use the modified macro, so that's probably that's okay. Direction of lateral mass screw is so superior and lateral is the majority, and that's the right answer. Okay, if you break lateral mass of C5 on the left side in a C4, C6 construct, then you will okay, abandon the procedure. No, so basically I think the right answer here will be skip that level.
That's because it is the middle of the construct, so you can easily skip that level.
Sandeep, you mentioned that in your presentation.
Yep.
Okay, and with cage placement in ACDF, what curvature should be the objective? So straight lordotic is the answer of the majority. Salman?
Yeah, that's fine.
Ideally, screws placed for CCDF should be directed. Probably that's ACDF. That's probably a spell.
Yeah, I didn't teach them REL, so more than half are going other way. So I don't know.
Okay.
We do it medially in a way to avoid to make sure if it sags, then it should be okay. It comes neutral, and away because sorry, medially is because we don't want the screws going into the vertebral artery laterally.
Okay, so the next question is overall risk of recurrent laryngeal nerve injury is, so the majority answered 2%, and I think this is good answer.
Yeah, hoarseness happens.
Yeah. Damage to ipsilateral sympathetic chain would cause Horner syndrome. Good 85% are right here. Okay, next one. What is the risk of infection in ACDF? So the risk of infection, so most of the participants say less than 1%, that's right. Usually if you have infection, you have to explore esophageal injuries. Professor Sharif stressed on this. Okay, next one. I think that's it.
Sandeep, you want? Sorry, Nikolay, you want to tell us about, or Mehmet, you want to tell us what we have for future?
Imat, do you want to? Okay, perfect. Okay, so so the next how I do it webinar will be on 24th of the 10th. That is in 3 weeks from now, and we are going down the spine. We are going with cervicothoracic junction. We will have 2 main approaches that will be discussed: manubrioperitomy, and then we will have thoracotomy. So the posterior approaches to the cervicothoracic junction will be left for another session. After. Okay, so I think we are coming to an end of our session today. Any other comments from the moderators and from participants?
We just need to have a group photograph. So if everybody switch on their videos, and then we have moderators to thank. Can everybody switch on their videos so we have a group photograph? Thank you everyone for joining. And Mehmet, your thoughts?
Everybody say webinar to smile.
Thank you.
Thank you.
It was great talks. Yeah, very nice. Thank all the speakers and thank all the participants.
Thank you, everybody, and have a good the rest of your Sunday, if still there is something left.
Goodbye.
Bye-bye.
All right, bye-bye. Thank you.